presenting on hemolytic anemia with thrombocytopenia. Did you check B12? So for background, vitamin B12 deficiency occurs in 6% of adults younger than 60 years old and close to 20% in those older than 60. This may be due to a variety of reasons, including malabsorption due to conditions such as pernicious anemia, where a special protein called intrinsic factor that binds to B12 and is absorbed by the stomach is missing, as well as malnutrition, where patients that might be vegetarian or vegan and don't eat a lot of animal products or fortified foods, as well as dietary supplements which have a lot of rich B12. Increased demand such as pregnancy and medications such as proton pump inhibitors and histamine blockers that are usually commonly treated for GERD and heartburn that can lead to B12 deficiency. B12 deficiency may present with fatigue and pallor, glossitis, mouth ulcers, jaundice, peripheral neuropathy, subacute combined degeneration of spinal cord, and neuropsychiatric diseases such as dementia, depression, and paranoia. And these can be seen here on the symptoms on the right as well as here on the left. We present a unique case of a patient who presented with initial concerns for thrombocytopenic purpura, TTP, but later was found to have severe B12 deficiency. So in the case presentation, a 79-year-old male patient with a history of Guillain-Barré presented to the emergency department for evaluation of chills, urine retention, weakness of bilateral lower extremities, and confusion. The physical exam findings were significant for hypotension, tachycardia, BMI of 19.3, gross hematuria, strength 4 out of 5 in bilateral lower extremities, and orientation to only person and place. The laboratory results were notable for thrombocytopenia of 17 K per MCL, which normally is platelets are normally around 140 to 450. A total bilirubin of 4 that's elevated, a direct bilirubin of 0.4, indicating indirect of 3.6 or hemolytic anemia. An elevated AST, ALT, ALP, and anemia with the hemoglobin 11.6 with an MCV of 81.8, and an elevated white blood cell count of 18.4. As well as an AKI with a creatinine of 1.76 since the patient's baseline was 0.9, and a UA with the erythrocytes greater than 100 HPF and pyuria of greater than 100 HPF. In light of the patient's renal with the elevated creatinine and neurological symptoms that he came in with the confusion, as well as the thrombocytopenia and hemolytic anemia, we were concerned for TTP. So we calculated the patient's plasmic score, which is a score to indicate the likelihood the patient may have TTP, and it was 7, indicating that he had a 72% risk of severe Adams TS13 deficiency. And thus we sent for Adams TS13 testing, which only came back weeks later after the patient was discharged at 10% or greater than the cutoff for TTP, as well as the blood smear. The blood smear showed leukocytosis with the reactive neutrophilia, normocytic anemia, and thrombocytopenia with unremarkable red blood cell morphology, and no schistocytes were identified. The patient's B12 level came back severely low at less than 45, and the folate was also low at 1.9, and as well as the iron at 5, and the TIBC of less than 36. And due to the presence of these multiple elemental deficiencies, testing for pernicious anemia was held off during the patient's hospital stay. The patient was ultimately started on 1,000 micrograms of intramuscular cyclobalmin for 7 days, and the same dose weekly for 4 weeks, and plan to continue him on therapy thereafter, as well as 1 milligram of folate. And the patient was able to recover his B12 and folate by the end, was able to recover his platelet count by the end of discharge. And it was likely due to his malnutrition, his poor diet. And as seen as our patient, early testing for B12 level is crucial for patients that present with concerns of thrombotic microangiopathies. Because although severe B12 usually presents as pancytopenia, this finding was unique because it was confounded by the leukocytosis seen in the patient's urosepsis. It should be considered indifferential in patients with thrombocytopenia and hemolytic anemia. And B12 deficiency can mimic TTP and HELP syndrome, which have been reported and caused unnecessarily plasmapheresis and termination of pregnancy. Thus, therefore, B12 should routinely be ruled out in patients with concern for thrombotic microangiopathies, as treatment is less invasive and cost-conscious compared to other treatment modalities.